Case number 1.
Thank you.
Thank you.
State your
Read
case.
by yourself.
Now you got the judge here.
Mike.
Time.
I can't video, I gotta write. Can't we just balance it?
You?
Can we balance it?
Read.
Really? Yeah.
45 years old male comes to your clinic complaining left heel pain for 7 months. He denies any specific trauma to heel or foot. Medication provide temporary relief, but over pain has been getting worse. In general, pain is 7 out of 10 when he takes his first step in the IM or after sitting for 30 minutes, and then diminishes as he moves around. He additionally complains increased pain when standing for more than 20 minutes. Though he is 57 pounds overweight, he enjoys walking 3-5 miles per day and hopes that this will help him lose weight. He recently has to stop his walking regimen due to pain. His goal is to return to walking 4-5 times per week. So we are thinking that this is plantar fasciitis.
Okay. You're saying it's not frozen shoulder, right?
No.
Okay.
Good.
So far, so good. And next person talk.
Okay. Intrinsic factors for the diagnosis would be low arches, which would be too much motion, will be caused by too much motion in the rear foot and midfoot. And high arches would be too little motions in the rear foot and midfoot.
Next.
Extrinsic factors for this diagnosis would probably be prolonged standing or ill-fitting shoes. And some activities that will probably cause the patient pain will be negotiating stairs.
Wait. What other extrinsic factors?
Prolonged sitting and prolonged standing?
Prolonged standing,
Ill-fitting.
ill-fitting shoes.
And overweight.
I stumbled a bit when I was speaking.
And
What else?
overweight. BMI over 30, 25 to 30.
This person is 57 pounds overweight, so BMI of 25 to 30, yes. Good, all right.
Poor training for footwear.
Or training for footwear, I like it. Darren?
Patient will feel pain on the anterior medial heel or the center of the foot.
Wait, what about activities?
Yeah, what activities?
Okay, so pain with first steps after an activity. Usually it's in the morning or just sitting down. At the end of the day or prolonged standing.
Sitting.
Standing, or just regular walking, running, or climbing stairs.
So repeat it so I get it.
Yeah.
AM more than PM, which one?
AM.
AM, for sure, the first steps in the morning, good. Also after prolonged inactivity, like sitting at his desk for an hour, then getting up would be very painful. Also if he has a job that involves prolonged standing, especially with his BMI. Right?
Yes.
All right, good, keep it up. Celine?
The pain will be in superior medial heels.
Show us on somebody's foot where that is. I don't speak fancy. Superior, medial, inferior, inferior.
Like here, around
Where?
here.
Yes, for sure.
Higher.
The medial, superior medial heel, for sure, right? And where else? Where else?
Center of the foot.
Center of the foot. Those are the two classic spots. Good. Next.
Passive range of motion testing will reveal tightness and range of motion deficits and hamstrings. That's probably because tight hamstrings means decreased knee extension, which during initial contact you're going to have other parts of the foot touching the floor where it shouldn't be.
If you don't understand, ask. Ask it.
So if you have tight hamstrings, that's going to affect the way that you walk during initial contact. So when you're putting your foot down, other parts of the foot will be touching the floor, pretty much where it shouldn't be. It should be touching the heel.
Oh.
Everybody get that?
Yeah.
Because you can't dorsiflex, right?
Yes.
So you're
It's not necessarily
So
about
we're doing hamstring.
hamstring.
You can't ask.
So like basically, instead of going like this, maybe it might be a little bit more like this, and then other parts of the foot are touching the floor, rather than just the heel.
Everybody got it? Yeah, no questions?
And tight gastrocs.
No? Good. You explained it well. No one had a question.
And
This range of motion is in dorsiflexion?
dorsiflexion as well. So decrease range of motion dorsiflexion because of tight gastrocs for the pretty much the same exact reason.
If you don't understand, ask. What is this, osmosis? Does everybody understand those two concepts?
So again, tight hamstrings, instead of going out like that, it's probably be more like this. Other parts are touching the floor where it shouldn't be. Also for tight gastrocs, instead of being like this, it might be more like, maybe more plantar
So
flexed.
like the forefoot.
Exactly.
First.
There we go.
Yes. When you're in swing, you need terminal knee extension. That allows your heel strike to occur. If you have tight hamstrings, you don't get full terminal knee extension. Even if your knee is flexed a couple of degrees, then your heel is not hitting first. Like Alan said, other parts of your foot hit first, what can create this plantar fasciitis. Everybody get that?
Yes.
If you have tight gastrocs and or soleus, but gastrocs, then you don't have full dorsiflexion. You need good dorsiflexion to have heel strike. If you don't have full dorsiflexion, then your foot will hit the wrong way on the floor, and doing that for multiple times will create plantar fasciitis. Does anybody not understand that concept? You speak for everybody. Everybody got it, Josh?
Yes.
Everyone not get it?
Aye.
Good. I thought Alan's explained it great.
He's, yeah.
All right, Joanna, next.
So, what test would you use to rule in this diagnosis? So, to rule in this diagnosis, we choose windlass test.
Show us.
So, put this on mat.
Put the 50-pound weight on it. We love no socks.
The long sitting.
Socks are off?
Socks off.
Yeah. So windlass test is passive toe extension. So you have to bring passively toe to extension. Doors. Yeah. And if patient is feeling pain, tingling, numbness, on any unpleasant feeling,
Yes.
is
Symptoms
plantar
will increase
flexion.
if you do great toe extension, right? Because why? Joanna, why?
Because in this position, plantar fascia is stretched.
Correct. It's
So-
Taut.
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 It's taut. That's right. So if you have plantar fasciitis, doing big toe extension will increase symptoms. Very good. What else?
And you wanna measure? I have dots.
What's another one?
Medial longitudinal arch angle.
Yeah.
Let's do an easy one first. What's another one? You said tight gastrocs and soleus, which you
I was talking about tests.
yes. What
windlass
other
test,
tests? What other tests would you do?
and
Before medial longitudinal arch, what's another test, huh?
medial longitudinal arc.
Okay.
Passive.
Yes.
motion?
How about you said hamstrings are tight. How do we know hamstrings are tight?
Because
Check
we
your
can observe
range
the
of
patient has lacking knee extension, or what do you?
How do you know they're lacking knee extension? How do you know it's the hamstrings? What test could you do to make sure it's the hamstrings?
Stretch, hamstring
Show us
stretch.
the passive straight leg test.
Oh,
Yeah, we
okay,
will stretch it
so-
this time.
Okay. So I can raise patient leg. Okay.
And if they're tight,
Feeling, stretch. So,
That's tight.
yes, I like to say if they can't get to 90
Okay.
degrees, there's definite tightness. 60 to 70 degrees tightness, right? If it, let's say at 20 degrees, you can't move them anymore. What does that mean?
120?
No, 20.
Oh, 20.
Sign of the
So
buttocks.
Is this your group? Mike?
Shut up.
So you're asking the
You're
group.
filled with, he's just filled with knowledge. He has to share. Yes, sign of the buttocks. You remember sign of the buttocks?
She knew it.
We talked about it earlier today in neuro.
And radicular pain would usually come up where, around where? Ooh, it's something to ponder, something to ponder.
On the groove.
More than,
Right?
if you go more than 70 degrees, and there's pain shooting down the leg, that would be radicular symptoms. Passive straight leg rest, a positive sign is about 70 degrees or so. There's tightness in the hamstring. I'm taking us back to the oldies. You'll review it. All right, so, good. What else? So now you're talking about the medial longitudinal arch angle. Because we discussed earlier that what? That high arches or low arches can contribute to plantar fasciitis. So show us how to do properly, find the medial longitudinal arch angle.
So you have to find
patient should
medial malleolus, navicular, and
the first metatarsal
head, and make dots in the middle.
And then we measure the ankle, this ankle.
At the navicular, the medial malleolus, and the first method.
I want to hear out loud, what are the bony prominences?
That's it. The medial malleolus, the navicular, and the first met head.
Where in the medial malleolus?
Everything on the center.
The
Center.
center, okay, next. What part of the navicular?
Also on the center of
Navicular.
the navicular
The tuberosity.
Tuberosity.
on tuberosity.
And the last one?
The center of
Big.
the first met head of the big toe.
The first metatarsal head, okay, good. All right, then what do? You probably already did it.
Yes.
Take the measurements.
What do you do before you take the measurement?
Draw the line. I'll draw the
What were
line.
you
Sorry.
doing? See how much they learn? You can't keep it to themselves. Yes, let me see the lines.
So eager.
So eager.
Share the
You
knowledge.
draw a line between, oh, that's,
Dot.
you
We
draw a
put-
line
we put
between,
dots.
so, show us. Do you mind if you draw the line?
Draw it.
Draw it.
You mind if we?
Drool.
No, Mike said stop sharing. He's not
No,
sharing.
you can't draw on skin with a pencil.
I thought it was a pen. It looks like a pen.
Use your goniometer to draw a line between the two dots. Very good. Look at this. This is
Oh, that's
this
a good
is
spot. Sway.
YouTube video worthy. Good, and then a line between. Good, excellent. And then you put the goniometric center. What do you call it? The center?
Fulcrum.
Fulcrum. Right. Ask Mr. Mitchell the last time we've used a goniometer. Not yes, the fulcrum. Ah, very good. And you make sure you do right by those lines. And what do we have?
A nice angle.
140.
140. Yes. So what is normal?
131 to 152.
131. Very good. 131, 52 is normal. What'd you say? She's almost abnormal. 131 to 152 is normal. Above 152 is considered a what? 140. So she's
140.
perfect. Right, perfect. Above 152 is considered what?
High arch.
A high arch. Below 131 is considered a low arch. Joanna is perfect. Perfect. Amazing. All right. Good. Based on the findings, they have a low arch. Move on. What muscles should be strengthened if they have a low arch?
So the tibialis posterior.
Tibialis posterior. All right. Also, I want to mention one thing, that medial longitudinal arch should be done in sitting like you did, but also in standing. And if the person has very low arch support, that number should decrease normally when they're standing, but if it decreases significantly, that's something to think about. Okay? Very good. All right, next.
So what test would you perform to rule out the diagnosis? What's the positive sign? We'll do the tarsal tunnel syndrome test.
Darren's on.
You'll do it to me? Sure.
Tarsal tunnel.
There's a lot of tunnels in the body. I don't know if you do that. Carpal, radial tunnel syndrome, cubital tunnel. sitting.
Let's get this out the way. All right, so I go towards the medial malleolus. I do max plantar flexion, eversion,
In eversion?
inversion, sorry.
Thank you.
Inversion, and I hold near the medial malleolus for about 30 seconds. I compress it to compress the tibial nerve. And then if there's any type of numbness or tingling,
Take the sock off.
true.
Right here. There you go.
So if there's any type of numbness or tingling, then that's going to be a positive sign.
That's not,
Sorry?
that's not plantar fasciitis.
It's not, yeah, it's not plantar fasciitis, it's
And where would you feel
TTS.
numbness or tingling?
Toes, heel, yeah, the foot, basically.
Ball of the foot,
Big toe.
the big toe, or the heel. All right, very good. Now that you've done all these tests, go on.
All right, so now it's gonna be like phase one for the plantar care. So let's say we wanna stretch the tight structures. We wanna stretch the hamstring, the gastrocs or the soleus. But for phase one, we have to do non-weight bearing. So what we can do.
Show us how do we do that.
So for a hamstring, let's say we have a belt or some type of rope. They can just do a hamstring stretch, just like that.
Wait, let me see a hamstring stretch. Mr. Mitchell's making that face and he's not
I'm
happy.
looking at you laughing.
I'm not laughing. Teach the patient how to do a hamstring stretch. It's the real world.
Okay, we got a towel.
Look at your foot.
Yeah, the 80-year-old patient will love that one.
Or they can sit down,
No, this is non-weight bearing?
non-weight bearing,
Okay.
like that. Obviously, you just wanna have wheels, they'll just bend down just like this.
All right, hamstring. Now what about gastroc and soleus, non-weight bearing?
Gastroc, let's say, to get the soleus, because they're gonna bend the knee, bring out like that.
That's how you stretch the soleus.
Well, technically, like,
Well, you won't feel much of a stretch.
I mean, like,
How would
technically
you do when
because
you feel
when,
a stretch?
because in order to stretch your gastrocs, you would pretty much.
I know what you have to do, but if you're doing that position, I don't feel much of a stretch. What have we do on the table?
Long seating.
I guess.
Maybe TheraBand.
No, TheraBand is never used for stretching. If I see TheraBand for stretching,
You
Mr.
failed.
Mitchell's gonna have to do one of his moves on me.
You failed.
So this, alright,
I didn't say it.
so again, this can be done. I guess you also get the hamstring, but you also get in the gastrocs and soleus. By doing
That's the
this.
gastroc and soleus.
There's no story.
You can.
Bend.
Bend the knee. Bend the
Oh,
knee
bend
for
the knee.
soleus.
Sue and catch, sue and catch.
Oh, there
Have
you go.
him show him what to do.
Thank you.
That's for what?
This would be for the soleus,
Yes, and for the gastroc?
gastroc, without.
All right, we'll buy that.
What did you have in mind?
No,
No,
we
I
just,
mean-
you know, we know you know it, how to talk it, but you have to know how to do it. That's all I'm saying. There's a bridge. It's a bridge. All
Where's
right.
your belt?
If I could take it off, I'd give it to you. All right. We're also doing joint moves, are we?
Yes.
Grades what?
1 and 2.
Okay. Show us the moves you'd be doing.
Mob it up.
I'm talking.
Well, Alan's learned his lesson. Mr. Mitchell. You're done talking. You're done being talked to.
Try that when you're comfortable now. I'm tired of talking.
So we do the
All right, what are we
AP
doing first?
We do the AP glide on the taurochoroid joint.
AP glide towel crural joint.
Yeah. So I destruct the joint first and do posterior glide like this.
Now you're holding the bottom.
Definitely review that move from the Mo flexor, right? All right, what's next?
Posterior glide and inferior glide of the first metatarsal.
What, which one now? Posterior and inferior?
Posterior and anterior.
And who?
the first
Anterior.
anterior
I
and
need to make this
posterior.
back here, I can barely hear anything.
Posterior.
Anterior.
Good, so how do you do it? Where do you put the supporting hand? On where? On the first metatarsal head?
Yeah.
I don't see it there.
Here.
No, close.
Here.
That's good. Distract?
Distract and do.
Yes, I don't wanna see flexion and extension, I wanna see up and down. So distraction can be done with the anterior and the posterior glides, or distraction can be done on its own. You got it? All right.
This.
What is one more?
That was only two.
Distraction, the
No, we did
subtail.
this, they did distraction, where they showed you distraction, that can be on its own.
No.
AP and PA glide I'm considering are at one. Okay, AP of the talus crural, and there's one more I wanna see.
Distraction of the
Distraction of the
subtalar.
subtalar joint, so you are putting your supporting hand, no, up, on, above, over, the medial and lateral malleolus? No, your calcaneal hand is perfect.
Okay. Wait,
Yes.
Right here.
There, and just distract. Good. There's no movement, just distraction of the subtalar joint. You're pulling the calcaneus away from the talus. You really have to make sure you are, excuse me, your arms. Here.
That's a bit of sarcasm in there.
No. Here. I'm gonna show me because we never, it wasn't one of the distal tib fib, and you're grabbing onto the calcaneus and you're distracting the calcaneus from the talus. That's it. Got it? It wasn't a slide, but I mean, it wasn't part of our mode lecture. All right, good. Those are all of them. Definitely know how to do all of those. Something fierce. All right. What manual technique can you do on the patient?
Anyone?
Deep friction massage.
How do we do it? Do it on the patient, Darren.
Alright, Alex, can you lay down over here?
Go. All right, so.
Alright, so we're doing a dorsiflexion, and then we're gonna extend all the toes, and then we're gonna dig deep on the plank.
Whoa! It's ticklish.
You're gonna do
Oh, I thought it was
extension of the big toe.
Oh, big toe only.
Yeah,
And
and
then-
you're gonna take your knuckles and dig into the affected area, which is either the medial heel or right in the center.
Right.
But you're gonna work it, you're gonna work it.
If it tickles, you have to go harder.
Yeah.
Going into dorsiflexion is also a good idea. So dorsiflexion, extension of big toe, dig in. Yeah, they'll even do when one thing gets tired, do the other. You're basically working the crap out of it, right? All right, now that that is a good. How would you teach the patient to do it on themselves?
So you can do it on your house. You can just extend your big toe, and then with your right hand, I want you to put pressure on the medial heel and at the center of your foot.
Good. What else could they do at home?
Water bottle.
All right, so we learned this, right? We learned this way back when. So the ice is on the floor, near a wall.
Put a towel.
Yeah, let's get a
Of
towel.
course you put it. This is a very clean, hygienic clinic.
It's back and forth.
Yes, you dig in with the ice. Very good. Good. That was phase one.
Oh yeah. Oh, okay. I got a plank on dudes.
Good. All right. Rehab phase two. So now, how do you? What, rehab
about-
phase two?
No, we
Sorry.
just do 2 exercises to improve arch support.
Penny and pin.
Oh, we're doing the arts. Is that now or that's later? All right. Show us. So the penny and the pen have 3 phases, right? So in phase one, oh, hello, Emily. Hello. Hello.
Are you done?
Got answers?
Go on. Show us the penny and the pen. is a fancy group. They're doing the quarter and the pen.
Ah,
So explain it, because no
We got
one
money to spend like that.
big money.
Alright, so pretty much the penny or quarter in this case goes under the first met head, and then the pen is going to be under the arch. So I'm going to be putting pressure on the penny while also trying to raise my arch. I can't really see that well, hold up. Kind of like that.
I see it.
So the pen just keeps your arc.
Yeah, I'm just trying to get away from the arch. So by trying to focus over here and raising the arch over here, that way the pens are faster. I'm trying to promote a higher arch.
What about
Wait,
the
I
tennis
missed
ball?
it. I missed
No,
it.
he did it perfectly, don't
You
he?
did it perfectly?
Nailed it.
Yeah.
Nailed it.
Yeah, the penny was on the metatarsal head?
Yes, sir.
All right, so that's phase one is what? Phase one, the easiest way to do it is how?
Again, I guess. So just staying still like this under the first met head, just trying to put pressure on the penny while also trying to raise the arch, get it away from the
So
pen.
the thing is that your toes have to be relaxed. Because if your toes aren't relaxed, then the toes are doing the work. Your job is to keep your first metatarsal head on the penny while your arch away from the pen.
Wait.
Your arch cannot, you put the arch, like, what is this, you shot him straight through?
How am I supposed to go?
Whoa. Alan, you were good?
Yeah.
So, also it's
Yeah.
not completely under.
Not supposed to.
Are you telling me? I'm lying on the floor here, all right? I want you to lift your arch off the pen. Put this foot back.
Relax
Keep
your
your
toes.
arch off the pen, relaxing your toes, keeping your head. There you go. You're forced to work the posterior tib. Do you see that?
I see.
Hands off there. Stand up tall. See, if you look here, you see he's raising his arch. He's working his arch.
Under there.
Right here. Work the arch, Alan's.
Work it.
But his toes have to be relaxed.
On the
His first
catwalk.
metatarsal head must stay on the penny. His arch is not touching. They call it the penny and the pen. In Canada, if you look up on YouTube, you'll find like the loonie and the pen. Because, you know, they're Canadian. Loonie is their $1 coin. Or the peso and the pen in some countries, many countries.
So the big toe is
The
stationary?
what? The crooner in the pen is good.
But the big,
The shekel in the pen?
The
What?
toe
the big
is
toe is stationary?
The metatarsal head stays on the pen, on the penny.
Oh.
And the toes are relaxed. Or the quarter, and your job is to not touch the pen. But you're not shoving the pen all the way through because you're putting it right by the arch, in the center of the arch. You got it? That's level one. That's easiest version, right?
So,
A more difficult version of this, show us Alan's.
1 second.
Same starting position, good. Now you're doing the same thing, but the patient is standing on one foot,
Oh.
not holding on to anything.
Uh-oh.
Now, the patient is standing on one foot, not holding on. This is much harder. His toes are still relaxed. He is not touching the pen. He is not lifting off the, you see how that's much
This is
harder?
phase
Yeah.
2, right?
That's
Phase
medium
two.
to
Oh,
hard.
okay. Yeah, he's not there yet.
I'm just, it's right here. Yeah, not phase. Phase three is move that table. I don't know, even know why there's a table there. Move the table away. Move the table away. Phase three is the patient is standing a little. The patient is standing not touching the wall, but right near the wall. And this is perfect because I can have. I can do something like this. All right, now stand on one foot. Right hand touches there, left hand, right. You see, it's much harder. Because when you're going to this way, your foot wants to go flat, but you have to fight the arch. The other way, your foot wants to fly off the penny. When I'm doing this way, well, with this foot, when I'm going this way, my metatarsal head wants to come off the penny. My whole body is going away, but I have to fight to keep the metatarsal. Once they supinate, so you have to fight not to do it. And when you're going into the arch, your arch wants to flatten and crush the pen, and you're not letting it. So that's phase three. You got your 3 phases?
Pen crusher.
No, and all these exercises, no sock, no shoe, no sandal, bare feet. All right, good. So those are the 3 phases of the penny and the pen. What else? How do we stretch the gastroc soleus and hamstrings in weight bearing?
So gastrocs is always at the same time, against the wall, going forward like that. Hamstrings and weight bearing, I guess you could do downward dog, like that. Let's say if they're older.
Wait,
again-
let me see that.
That's
Say it
downward
again.
dog.
Do it.
Just touch your
Downward
toes.
dog.
Ah, shit, okay.
Oh, I got a yoga expert, Liz. What
That's
do you
not
think?
downward.
That's
Somebody
downward
show us
dog?
downward
Getting
dog.
there,
Yeah.
You're here.
Yeah, I can do that
You
one.
can.
Can somebody show us the downward dog?
Liz?
Darren, you can do downward dog.
I can't.
You can't
Anybody can do a downward dog.
Not in socks, you're gonna
You guys are
slide.
PTA.
Yes.
So that stretches the
downward dog.
hamstrings.
Yeah,
You
bring
wanna
those
keep your
heels
feet
down.
flat on the floor. Yes, your heels on the floor.
There we go.
And you want right, and you want to push your chest towards your knees. Right? And if you do that right, you should feel a stretch in the hamstrings and the gastrocs. How do you stretch the soleus?
Even Liz is like that.
Do the knee bends, basically, what was that, I think, runner stretch, it's called?
You got that running stretch?
It'd be your back foot, wouldn't it?
Who texted Kevin and told him to email me that he was
Oh,
sick today?
back foot is what?
No, you're stretching
So I got an email at
So this
4:15.
one,
Keep this straight.
I did.
No one did, huh?
For soul, you just.
Maybe you just came to.
this one is the.
He says, I thought I sent an email, but I guess I didn't. So someone definitely said that.
I don't look out for that.
You just tell me you just like
Kevin
I use gin.
Oh, sorry. Who texted him? I want to say make sure to thank, all right,
Who did it? Who done it?
It's Dr. Angle.
all right,
Alright, so then, yeah.
all right. So we got that. The joint mobs now are 3s and 4s, the same exact mobs, right? You know how to, make sure you know how to do all, if you pull out of the hat that case, you better know how to do all the mobs. The more aggressive manual technique just means you're doing further extension and further digging in. Or if it's the frozen bottle, you're putting more weight on the bottle, correct? All right. And you saw the whole progression of the medial arch support exercise. That's it, right? Good job, guys. What do you say, Mr. Mitchell? Give them claps after all. All right. Group number 1. Group number 1, go up there. Oh, number 2.
Oh, you mean group number 3. Oh, okay, I see.
Let
me get my stuff.
I miss the old days when you sat up there and stripped them out. Those days are over.
Can I put my stuff here? Thank you.
Oh, wait, I have a question. What you show, wait, time out. There's another exercise for medial arch support. Do we have Mr. Mitchell, do you have a ball of some sort?
Tennis ball.
Do you have a tennis, no, a tennis ball. All right, anything?
We'll have to YouTube that one.
A towel, yes, show us the other medial arch support exercise. No, you'll see, these guys are geniuses. This is another medial arch support exercise, which I liked. You chose like. All right.
Feature.
So, Sue Wynn is putting the towel in between her medial malleolus, right? Her knees are fully extended. Fingertips can be on the wall if needed. She's going up on her toes and squeezing that towel roll. She holds about 3 to 5 seconds, goes down and repeats. That is a good medial arch exercise. Thank you, Sue Wynn. Great job. All right, case number 2, go for it.
35-year-old male referred by MD with a diagnosis of right Achilles tendinosis. He has experienced a gradual increase in pain for 2 years and can no longer play b-ball. His MD has recommended surgery, but he would like to try PT. So,
Does that count as your part of the presentation?
yes,
No.
I tried. Demographics. More male than female, and basketball players between the age of 35 and 50 years old.
Go on.
And then, well, what else did we say? Oh, the next person, okay.
The difference between tendinitis and tendinosis. Tendinitis is acute injury. tendinosis is prolonged chronic, like degeneration or damaged collagen. And rupture can occur for both.
Two possible areas that this patient might experience pain are the midpoint of the Achilles tendon, which is 2 to 6 centimeters or 1 to 3 inches above the insertion of the calcaneus, or another area can be right near the insertion.
Manual muscle testing reveals weakness in dorsiflexors.
And testing active ankle.
Whoa there.
Oh,
You can't write
okay.
that fast.
DF.
I'm
All
sorry,
right.
dorsiflexors.
For dorsiflex, that's what the
Yes.
MMT would reveal. And then testing active ankle movement, athlete versus non-athlete. Non-athlete, you would do 20 heel raises, and a positive sign would be pain. And then athlete would be single leg hop or jump.
Wait, start from the beginning.
Sorry.
Blame the
Yeah.
Australian, blame the Australian.
It's all on video.
What are we up to? What are we up to?
The
You're up
testing
to,
now.
yeah, we
Two
just
possible
finished testing.
areas that would
Okay,
be
that's
tendon
it?
palpation.
Okay, where?
Yeah, it's the same answers before, 2 to 6 centimeters above the insertion, otherwise known as the midpoint, or at the insertion.
Okay, and what are those things called?
What are those things called?
One of them is midpoint, the other one is called
Midpoint,
insertional.
tendinitis,
Yeah.
tendinosis, and
Tendinosis.
insertional.
Who wants to-
This is what happens. They come, they give us, say hello.
It's like you guys are invisible.
Yeah.
Yeah.
You fill out the Google form?
Sorry, we're still learning.
Okay, who wants to-
All right, go on. Insertional and midpoint, very good. Manual
Yeah.
muscle testing, keep it going.
What's it?
The
We
test.
said that.
Oh yeah, I said the test, non-athlete 20 heels raises, positive sign with the pain. An athlete, yeah, single leg jump.
Okay, so special
you're right,
tests.
they'll have pain, I just wanna say, also, if that weakness is they can't do 20 for a regular person. And an athlete, like myself,
Be single leg hop, jump.
single leg hops. or
You in the
single leg-
summertime, not right now.
Not right now.
Wait,
All right.
for the heel raises, you would do double, right? It wouldn't
No,
be
single, 20 single heel raises is full strength in my book. If you're limited by pain or you're limited by weakness, that's a sign you're not good. All right.
How many single leg hops? Just one?
No, I do like 4 or 5, and if they can't do 1, yeah. All right, good. You said, right, the 2 areas we talked about. What about the special test?
Thompson.
Let's talk about it. Show us the Thompson test.
Thompson, Joe?
So the patient is in what position?
Wrong.
Patient is prone.
Yep.
Of course, we think about the heaviest work boot to take his shoe off. Yeah.
Still treacherous on those streets.
It is.
These are nice boots.
Oh, thank you.
Tim.
Alright, so the
So
patient
prone.
is prone.
Patients in prone with the
Is
feet hanging off.
Good. What do?
You just squeeze the belly of the gastroc like that, and you should see some plantar flexion, like so. If you don't see any movement of the ankle, that could be a sign that there's a rupture.
Okay, very good. That's a special test. So what protocol are you gonna use to treat this patient?
Of course.
Alright, so you're gonna show us midpoint tendon gastroc, midpoint tendon soleus, phase 1.
Okay, so, basically, in general, with anything where the pain is at the midpoint of the tendon, you have them on a step, and we'll talk about it later, but for insertional, they'll be on a flat surface, so that's the first difference. So for phase 1, midpoint of tendon gastroc, you will, do a heel raise, that's your concentric, and then you come down here.
Is this going below the level of the step?
Yeah,
Yep.
I think too. I'm working
Good.
up.
Very good. Up 2 feet,
Oh, yes.
down
Thank
1.
It's on.
Okay, yeah. Thank you. And eccentrically down.
Straight with the knee in extension,
Yeah.
is targeting the gastroc, and the knee in flexion, targeting the soleus.
Very good. What are you showing us next?
Okay.
So we did phase
That
4.
was out, now it's
Yeah,
insertional.
midpoint.
Or no.
So phase 2,
Two,
yeah.
yeah, that was phase 1.
Phase 2?
Oh, wait. Oh yeah, now for phase 2 for midpoint, gastroc and
wait.
soleus. mid-tendon. You know,
It's
you
just the
can
same
take
thing
out
that you
weight
asked
from
me.
there.
Yeah.
Huh?
Okay, yeah, he's doing it.
You could do that or a backpack.
All right, show us.
Yeah.
Phase two?
Say something.
Yeah. So
So you're
same
gonna
thing,
go
yeah,
up with
up
2
with
feet?
2, down with 1. Yeah.
Very
And then
good.
you do-
So how do you know when you're ready
Hold on,
for phase
so
2?
Keep it straight.
Are we doing solos?
Start with gastric, just show it. How do you know if you're ready?
How do you know when it's ready for phase 2?
How do you know when you're ready? Good question, Mike.
I'd like to know.
Alcohol.
Isn't it after a
I don't
couple
know.
of weeks?
2 weeks.
There's something specific we're looking for.
We don't know.
Can I answer my question?
Yes.
Go ahead, Joey.
If there's no pain.
There should
Yeah.
be pain during this exercise. Albertson likes pain.
Yeah.
3 or 4 out of 10 pain he likes. If you're doing it and there's no more pain, then your therapist, or you're the patient, your therapist should tell you, do it with a backpack or do it with a one of those guys if your clinic is inside a CrossFit gym.
Put a
Good.
tire
All right. So
over
that
the
was,
neck.
and you were saying for insertional, what are we doing? Any difference with
It's the
insertional?
same thing, it's
Flat
just on a
surface.
flat surface.
On a flat surface, not on a why?
Because if you go into dorsiflexion, there could be impingement of the bursa at the calcaneus and the Achilles tendon.
You get it?
Which
The
would be-
insertion of the Achilles tendon is right by the bursa, and if it's inflamed, that inflammation can push on the bursa, hurt the bursa. So you do the same exact exercise on a flat surface, up with 2 feet, down with 1. Phase 1 without any weight, phase 2 with weight when the pain reduces because you want a little pain. Good. Here's my, so we covered everything? Oh, and gastroc and soleus, we're doing, what's the difference? You said that already?
Knees flex for soleus.
Knees,
Same
back to
thing.
straight.
Now, here's my favorite one, Mr. Mitchell. Describe 2 modalities discussed in procedures 2 that would be effective for this patient. 3?
Laser.
Laser set to what?
2 to 5.
This one's
2 to
safety.
5.
Yes, 2 to 5 sounds
This is
good.
okay.
And what
It's
else?
Here for breakfast.
And ultrasound.
Ultrasound, so we have what duty cycle?
Okay.
Duty cycle 100% for tendon.
100% for tendinitis or tendinosis?
Tendinosis.
Tendinosis and a 20% duty cycle for?
Tendinitis.
Do you remember about the 20 and 100% duty cycle?
Yeah.
One produces heat, one does not produce heat, remember that?
Yeah.
All right, if you don't, please come back in the winter, where we will be teaching the course again.
Nice.
If you want to brush up,
For free, right?
you're not gonna charge you,
Oh, okay.
you can come,
Afforded any class.
you can come in any class,
All right.
you can help us
Cool.
teach if you're doing nothing.
Okay.
Do we get
All
paid
right.
for it?
What? Do I pay you for it? You see your wife's cutie paycheck? What do you mean?
And you could also use E-stim
E-stim is good for what?
for pain.
For pain, okay, good. What setting, what type of E-stim would you use?
No.
IFC, well, you talked before.
Yeah.
For the ankle.
Wow, I'm gonna start
Oh,
finding
Premod,
them.
Premod.
Premod is great, unipolar or bipolar? For the Achilles tendon. Unipolar, yeah. Or one on the gastroc, bipolar.
Yeah.
Good, all right, very good, guys. Any questions for this group? All right, finally.
Fine.
Moment we
Yeah.
want.
Guys, I'm gonna use that star right
What?
there, so you can show them.
Oh, yeah.
The Star of David. I should have the Star of David balanced.
Because I think yours is like short. The case is short.
All right, 52-year-old recreational athlete presents with inversion mechanism right ankle sprain times 6 days ago. The injury occurred while jogging in the woods with friends. The patient felt a pop in his lateral ankle and midfoot at the time of injury and was only able to bear weight for a few steps immediately afterward. Though all x-rays were negative for fracture, his PCP provided bilateral auxiliary crutches and was advised to remain non-weight bearing on the involved side until a professional PT evaluates him. No more information about medical evaluation conducted by his PCP was available. The demographics for this diagnosis is males and females are equal, although Latinos more than African Americans and whites. Next.
Okay, all right, what exact ankle movements occur during a lateral ankle sprain? You have forefoot adduction, hind foot.
Everyone do it, wait, everyone do it.
Oh,
Forefoot adduction,
So forefoot adduction,
rear foot,
hind foot internal rotation, ankle inversion and plantar flexion with hip external rotation.
One more time.
Yeah. Okay. Forefoot adduction, hind foot internal rotation, ankle inversion and plantar flexion, and then hip external rotation.
Most common ligament affected with the diagnostic is the anterior talar fibular ligament, 75%.
BTFL, yes.
You would suspect a DVT if the patient presents with calf tenderness, redness, swelling of the calf, ankle, or foot.
Wow, so monotone.
Yeah.
Say it again like evangelical.
It's funnier.
Calf tenderness.
Much better, much better. You gotta sell it.
Calf redness. And last, batting cleanup.
That's what we gotta do. All right, good. Ryan.
What test would you perform to rule out ankle fracture? A is tenderness along the tip of the posterior edge of the distal lateral malleolus. B, tenderness along the medial malleolus. And C, unable to bear weight for 4 steps. And these are also known as the Ottawa rules.
Yes, the Ottawa rules, very good. So, Ryan, if the patient presents with these things, what do you think it is? If they have tenderness in the posterior edge of the distal lateral malleolus, if they have tenderness along the medial malleolus, if they're unable to weight bear 4 steps, what do you suspect?
Yeah, I think I lost it.
Ankle fracture.
Ankle fracture?
Yes, yes.
Ankle fracture.
If they're tenderness and all those 3 places they can't walk, then you would think it's an ankle fracture. You tell the patient to go back to their doctor for an x-ray. Right? If they're all negative, then you don't assume it's an ankle fracture. All right, next, Ryan, since you're on the Ottawa rules.
What test would you perform to rule out foot fracture?
Yes.
A is tenderness at the base of the 5th metatarsal. B, tenderness over the navicular bone. And C, unable to bear weight for 4 steps after the injury.
So if there's tenderness in those 3 places, according to the Ottawa rules, Ryan, what do you suspect?
Okay, for the tendon and ligaments, there's problem with the tibialis posterior tendon. And
No, I'm asking if there's tenderness at the base of the 5th metatarsal, if there's tenderness over the navicular bone, if they're unable to weight bear for 4 steps,
all right.
what do you suspect?
The patient has fracture of the foot.
Fracture of the foot, that is right. And you were saying something about the navicular bone, which makes no sense to me. Where is the foot? Where's the foot?
At the bottom of
Show everybody where the navicular bone? They got jokes. The navicular bone is on the medial side. There's the navicular bone. Good. How is an inversion maneuver or a lateral ankle sprain have anything to do with the navicular bone? I get the medial malleolus because do an inversion sprain. Look what happens to the medial malleolus on the talus. That could fracture it, but I don't get the navicular at all. So why the navicular bone? What the hell does it have to do with the lateral ankle sprain?
Because, okay, go ahead.
We're off the hot seat.
Because the tibialis posterior tendon attached to the navicular bone. So it gets straight. Straight.
It gets taut. Don't be afraid to say it. Good. So when you do a lateral movement that gets taut, pulling on the navicular bone. Okay. What else is there?
The bifurcate ligament.
The bifurcate ligament.
Also attached to the lateral side of the navicular bone.
And therefore, when you do a twisting motion, it gets taut and could injure the navicular bone. You get that? Does everybody get that? Everyone gets that. Fantastic. All right. All right. So we ruled out foot fracture. We ruled out ankle fracture. What range of motion testing would you do, and what deficits would you find? Who's next?
Dorsiflexion.
Dorsiflexion. Or dorsiflexion, somebody said. Okay, good. Next, move on.
Where necessity.
Assessing the gait, you may find antalgic gait.
Antalgic gait.
Antalgic gait. Antalgic gait. That is correct. All right, next.
Oh, we gotta do this over here.
Josh is gonna perform the historic snow.
Miguel. Let's stay here.
Here is the star. Which, how many years ago did the kids do it? I think we're ready for a new star. Falling apart. 4 years. You know, what's it called? That guy with the saxophone.
Over here.
That guy, yeah.
She's looking at the holiday food dress.
So,
This test is null and void if I lose balance, if I put too much weight.
Which foot are you putting in the center?
This one, left.
So that's your left, you're testing your left.
The involved
So wait,
foot.
tell us all
Is it the
positions,
affected
please.
foot that you're putting in the center, or
Michael, tell
not
us all the
affected?
positions.
He's gone.
Anterior,
Yes.
anterior, lateral.
Ignore me.
Isn't this medial?
It's medial.
Medial to your
based
left
on
foot,
the
though.
standing on the foot you're standing on. The tested foot, that's medial.
Oh, I see. Anterior, anterior medial, medial, posterior medial, which is the hardest one.
So posterior medial would be the, if you have a lateral ankle sprain,
Yes.
the posterior medial will be the most difficult to do. Okay, you got that?
Posterior, posterior lateral, lateral, anterior lateral.
Got it? Very good. That's
Just
a
a little
star
toe test.
excursion test. Very good. And if, what's another test you could do?
On this?
If you don't have an old student that created a star excursion, what other test could you do to test the integrity of the ankle?
Oh, tailored tilt test and anterior
That's a
draw.
special test
Oh.
that you have the patient do.
Single leg balance.
Single leg hop.
Hop?
Hop. If they're ready for it, they can do a single leg hop. And if they cannot sustain that, if they can't even do it, it's too painful, that's good. All right. Now, because I taught you the figure eight so horribly, we're gonna have this group do it right. So show us on for video. This is the video. This is the one you're gonna watch to do a figure eight.
Hey, this is good practice.
So make sure the patient has no soccer feet. They are completely non-weight bearing. Talk it through. Who's doing it? This is your big moment, Diana. You've been practicing forever for this.
No. Wait. So we're gonna start on the lateral malleolus, inferior to the lateral malleolus. And
So
then,
between the lateral malleolus and the anterior tib tendon.
and then we go around navicular tuberosity.
So your
White balance is messed
inferior
up on
to the anterior tuberosity, like not. You feel the anterior tuberosity?
Yeah,
You're
yeah.
right in- You're right
Yeah.
in front of it.
Mhm.
Good. Go
And then
on.
you cross over the feet,
Tuberosity
tuberosity of the feet,
base of the fifth metatarsal.
here.
Oh, right here, fifth medicine. Right here, sorry, right that bump, the bump, yeah.
And then you go over the anterior tibia tendon,
But under the malleolus. Under the there you go.
and then just,
Around the Achilles tendon, under the malleolus, the lateral side. Go back to the
people
X.
sick.
Sorry, am I talking too much?
and then just go back to the lateral.
Measure here. Aquí.
As long as you like you can measure here.
Do we have to do this for the final?
Of course.
You get 18?
20,
20.
19.
Good. You guys got it? Any questions on the figure eight? You got it? We got it?
Good job.
Hello? We got it? Very good. All right. So that is it. Now, where are we up? Special tests? Yes, that will be on the practical or the written. Know how to do the figure eight, know how to do the star excursion. Everything today.
Tilt.
Sitting or yeah, okay, short sitting is actually probably better. So you do 10 to 20 degrees of dorsiflexion, which I would do, and then I would. No, plantar flexion. And then I do inversion of the ankle. And then a positive sign is if it's if there's excessive movement compared to the uninvolved side. So that was the first one. And then the anterior draw test can be done in supine or prone. So if you are supine, You can go back. I need a bolster. Can you throw me a bolster? You put it under the knee, so the knee is slightly flexed.
To
And
relax
then
the
you
gastrocs.
do slight, to relax the gastrocs, and then slight plantar flexion. You stabilize the tib fib, and then you move the calcaneus anteriorly, like this. And a positive sign is if there's excessive movement compared to the uninvolved side. And that's
Got
it.
it.
Oh, and you do it in prone if there was too much swelling.
So yes.
And then you do
anterior,
the
you do
other way.
anterior draw or Taylor tilt?
I did both.
Both.
Yeah.
So for the Taylor tilt, a positive sign is what?
Excessive movement compared to the uninvolved side.
You do both sides. And anterior draw,
Is also the same thing.
excessive movement compared to both sides. And you said if the patient's really inflamed, you could have them lying on their stomach and pushing straight down.
Right.
Okay.
Shoes. Grades? Anyone? Grade 1, no loss of function, negative on special tests, and a little bit of edema. Grade 2, some loss of function. When you do the figure 8 measurement, they'll probably have 0.5 to 2 centimeters of edema, a positive anterior drawer, but negative on Taylor tilt.
What? You said hematoma or swelling, what else?
Oh, range of motion,
Yes, but what else besides hematoma, and what else will they have?
swelling.
Point tenderness.
Point tenderness, very good.
Oh, tenderness.
Also point tenderness, so they are, yes.
Grade 3, total loss of function, lots of pain, lots of swelling, greater than 2 centimeters, positive on all the special tests.
Very good. All right, moving right along. Next.
Treatment?
Phase 1, acute phase. You advise weight bearing is tolerated. What assistive device would you recommend? Crutches, and for bracing, a lace brace for edema control. And what would you do to control edema? Soft tissue mobilization and ice for 30 minutes.
Soft tissue movement versus what? What's a soft tissue movement?
Massage.
Massage towards the heart.
Retrograde massage, right?
With
Towards
the
the heart,
elevated.
the leg elevated. Very good. Someone got that? All right. Next.
Joint mode.
Joint mode.
What joint mode would you do?
Antero-posterior glide, the talocrural joint.
Right, a posterior glide to the talocrural joint. If you don't know how to do it, refer back to the lecture, the lab. You can ask the lab, get good at it.
And then also isometric muscle energy technique.
What's that?
So basically just doing all 4 of the range of motions of the ankle, but with isometric. So you can actually either use your own foot to block, or you can use a towel, I guess. Sure. But what I had in mind was you can just actually cross your foot over. And then let's say you want to do dorsiflexion, you can prevent it. You can add resistance like this. If you want to do inversion, you can go this way. Eversion, you can cross it out, hold it like this, and plantar flexion.
ISO.
Push, put one on top of the other. Like one on top of the other. Yeah, like this. No, plantar flexion, like this, and then just pushing down against it.
Right, so.
So just hold it.
Isometric, good.
So that's isometric.
I did that.
That's phase 1, And then phase 2, active range of motion, non-weight bearing. You can do circles, or you can do alphabet. So you can write the alphabet using your foot. You can do open chain strengthening with a TheraBand.
Pretend it's a TheraBand.
Yes, okay, so that's plantar flexion. We're gonna need some other stuff.
Let me see what the alphabets look like.
Inversion?
The alphabet,
What's that?
I was pretending it was a TheraBand.
Get a TheraBand.
Somebody.
Never use a TheraBand for stretching and never use a towel for strengthening. And I taught you nothing. Let me see the alphabets.
Yeah, how do you do the alphabet?
B.
Now, guys, do you think you could use any language alphabets? How about some Chinese letters?
That'd be incredibly painful.
Spanish alphabet?
What letter was that?
Anything works, right? You see how the alphabet gets off? But here's the thing.
What did you say?
Here's the thing with the alphabet and the range. You want to make sure the patient is not using their knee. They could be cheating, so you want to make sure their knee is totally stable. Yes, that would not be ankle. So make sure they're using their ankle exclusively. They don't have, yeah, just remind them, hey, don't use your
She
ankle.
just likes to inflict pain at any chance, any opportunity.
Alright, so 4-way strengthening with the TheraBand. You can hook these around both your.
All right.
Keep them further apart to make it harder. Cross the other one over for inversion. You can do plantar flexion. Or you could really just hold it, which would have been probably make more sense, but yeah. So yeah. So that's open
Make
chain.
sure you know how to do TheraBand for all fall ranges, inversion, eversion, plantar, and dorsiflexion. Make sure you know how to do it. If you don't know that we see one weakness, we exploit it. So coming to the lab with weakness is not a good idea to the lab test. Everyone in this room knows that.
Yes.
Right?
Okay.
All
You
right.
assess the patient's gait and they don't display any antalgic gait. What would you advise regarding brace and assistive devices? Keep the brace, but no assistive devices. That's it.
That's
Balance
it?
training. Okay, yeah, and then we can do balance training on a stable surface uniplane. So basically just weight shifting on the floor. You can do reaching out.
So show me a two-footed.
Wow.
Let me see. Let me see. Let me see. Feet together. Okay. And this is also another one. When you're ready to see, this is easy. This is the hardest. Like this, walking the tightrope. That's the hardest way to balance with 2 feet. Do you agree with that? Tandem walking. So when they could do start
In neuro, we call it tandem.
tandem without pain, then I would have them stand on 1 foot, right? Reaching out of base of support. I like it. Show us how to reach out of base of support. Yeah. So what I like to do is stand against the wall, cones, or like I have them against the wall and I pretend that there's, when you roll a die, the 4. So 1 foot. There's one part of the 4, other part of the 4. I'm talking about 4 on a dice. Like that's good. And then finally on a unstable surface, you said?
That would be face.
Like your dog? Like what's an unstable surface?
Like a rocker board.
Oh, do we have one? Alan, let's go get the rocker board.
On this thing.
This is unstable too. Good stand up.
The discs.
The discs are good, the Bosu ball. Mr. Mitchell's gonna have all those toys in here.
The Erics.
Wait, hold on.
Whoa, it's hard, man.
Okay, well that's phase 3 technically, but yeah.
Easy there. What's next, Eric?
Well, that was it.
That one.
And then closed chain strengthening. So for plantar flexion, you can do, like cap.
Heel
Heel
raises.
raises, yes. For closed chain dorsiflexion, you can do squats, and for closed chain inversion, eversion, you can use a towel to either push it to one side. Yeah, windshield wipers, exactly.
Windshield wipers.
Yes.
Wipers.
I like it.
And then that's it. That's it for phase 2.
All right.
Wait.
So what is the quiz on Thursday?
What did we forget?
We don't know how to.
What did we forget? What did we forget?
Oh,
How do you
sorry.
control maladaptive overload?
Monitor pain, redness, swelling, and reports of instability.
What is maladaptive overload?
It means you're doing too much.
Yeah, you're
Too soon.
putting too much stress on the joint.
Before he's ready.
We have a quiz
Monitor
Tuesday?
pain, redness, swelling,
How are we doing all the
and
quizzes?
reports of instability.
Is it extra credit quiz?
No. No. No quiz. Our last lecture's on Thursday. Our last lab is on Tuesday.
That's it?
Right, Mr. Anything
So
to
we
say,
can
Mr.
skip
Mitchell?
Tuesday?
Huh?